patients coming in with a discordance in FSH and AMH, and that leads to a lot of confusion. So you come across cases with a normal AMH and a high FSH, or a high FSH and a normal AMH, again creating a significant amount of confusion. Or what you commonly see is a low AMH and a high FSH, and that's the common a place where you end up seeing a challenge on ovarian reserve. So if you come across cases of a normal FSH and a low AMH, or a high AMH and a high FSH, where do we start looking at these matters? And this paper was slightly more interesting because it gives you an idea. And as I've always said, one paper doesn't tell you all the answers. A paper adds to our knowledge. And as you keep reading and you build up your reserve of knowledge, and you're able to change your clinical practice, and I'll always keep saying that, is try and read something new every day. So, and this was quite a nice paper. And if you have a look at it, they looked at ovarian reserve markers, follicular phase FSH, AMH, and AFC. Day 2 high FSH and low AMH indicate poor ovarian reserve. In younger women, we don't know whether this discordance in AMH and FSH have any limited value. So 4 groups were taken with controlled ovarian stimulation and IUI or nature. So when you looked at the 4 groups, Group A, normal FSH and AMH. Group B, abnormal AMH and normal FSH. Group C, normal AMH and abnormal FSH. Group D, abnormal AMH and abnormal FSH. Day 3, FSH should be less than 10. AMH was age specific. Ovarian stimulation with IUI or nature, and 3 cycles. So if you look at the general from A to D, you can see the pattern. So when you looked at the results, when you had a normal FSH and a normal AMH, your chances of falling pregnant were the best. If you had an abnormal AMH, a low AMH, and a normal FSH, your chances of falling pregnant were still low. On the other hand, your FSH was high, but your AMH was normal, and the chance of falling pregnant were better. And when you had both low, your chance of falling pregnant were worse. So what is it telling us? It's telling us that in this study, the AMH seemed to have a better correlation to chances of pregnancy. Now, there is reasonable discordance seen, and pregnancy rates are lower if the study says the AMH is lower. Low AMH is a better predictor of whether combined with a high FSH or a normal FSH. So AMH in this study seems to lead the way of trying to predict success rates. Gleicher found that discordance does occur between FSH and AMH, and this can improve. And I agree with that. I tend to see it in my practice that if you have the patients, you will see AMH keep fluctuating, and you'll see antral follicles keep fluctuating, and that is what is essentially, it's quite important because you'll know when to stimulate the ovary. And if you create a haste in these cases, you end up having a very poor response. Remember, you can't change egg quality. If somebody tells you that you can change egg quality, it's wrong. It is age dependent and it is on the decline. But what you can try and do is you can try and stimulate when the chances of obtaining eggs is the maximum. And that sometimes does require patience on both our parts. Now, Mininaro also reported that one marker of abnormal outcome had a better outcome, but as soon as you had 2 markers, the chances of pregnancy went down. Now, no marker is perfect. AMH is superior to FSH in predicting high and good responders. FSH is better than AMH in predicting egg quality, and that may also be true. A high FSH is an independent marker of poorer egg quality compared to a low AMH, where low AMH is very much age dependent. And age is overcomes the low AMH in terms of quality and in terms of the quality of embryos. So if you look at the curve, your best way of assessing quality is looking at age, AMH, AFC, and FSH. Combine all of them and your predictability of a poor response is better. So again, a simple diagram in a textbook. So what you see is as the ovarian reserve is on the decline, you start seeing an increase of FSH coming up and the force of FSH increases, and that's how the ovary tends to function. So that's in short about a discordance paper, and I'll say the reason it's interesting is because we see a significant number of discordant findings. And here, I'll tell you my experience, and my experience is if the AMH is low and the FSH is high, that is a poor indicator, and I think you need to be very frank that your chances of doing any type of treatment tend to lead up in failure. But on the other hand, when the AMH is low and the FSH is normal, these are women who will recruit follicles in a slightly different way. And there is now evidence coming up in a recent human reproduction paper that said that AMH could also have a role in preventing the small preantral follicles from becoming antral follicles. And as the AMH declines, that recruitment tends to be faster, and you may be presented with a follicular growth at a time when you least expect it. The question is, do we have the patience? I call that chasing the antral follicle, and sometimes that is significantly important.